Myelomeningocele is the most severe type of spina bifida, in which both the spinal cord and the meninges protrude through a defect in the vertebral column. This disorder primarily affects the nervous and musculoskeletal systems, just like with any type of spinal disorder. But it secondarily affects many other systems, like the urinary and digestive systems. Hydrocephalus is common in more than 80% of cases, in which cerebrospinal fluid accumulates in the cranium, putting pressure on the brain, and sometimes resulting in brain damage or enlargement of the cranium. Myelomeningocele is treated by surgically closing the lesion 2 to 3 days after birth. If hydrocephalus is present, a shunt placement is also done at this time. Physical therapy is extremely important for gaining and maintaining mobility and function through all stages of life for a child with spina bifida. Therapeutic intervention depends on the location and severity of the lesion. Higher and more severe lesions lead to more functional deficits. Therapeutic intervention should include strengthening and balance, range of motion and mobility, independence and functional skills, proper use of orthotics and assistive devices, a home exercise plan that includes range of motion and strengthening activities, and family education about proper care and nutrition, positioning, shunt care, and contracture prevention. The use of orthotics is important for children with myelomeningocele in order for them to improve their quality of life and functionality. Determining what type of orthotics depends on the individual's level of motor function. It should be based on their needs and will change frequently throughout their childhood due to growth and other factors. The use of orthotics should promote mobility and independence. The family will work with a physical therapist to determine what would work best for the patient. Early intervention can have positive, long-lasting effects on how children with myelomeningocele perform in school, their social interactions, and their motor function. The term grounded cognition is used to include mental cognition, but also broader perceptual motor, language, and social abilities. It includes object interaction, sitting, and locomotion. Object interaction refers to how children explore the objects around them. Sitting can improve an infant's ability to visually process information. Locomotion promotes significant advances in problem solving and spatial memory. Although children with myelomeningocele may have delays in these areas, this study has shown long-term positive results from following this model. The hypothesis of this study by de Groot and colleagues is to assess both reliability and agreement of maximal and submaximal exercise measures in normal ambulatory and community ambulatory children and adolescents with spina bifida. The purpose of this study was to provide more information on exercise training for children and adolescents with this disorder, since there is limited research that has been done. 23 children with spina bifida who are normal ambulatory and community ambulatory performed a graded treadmill test measuring and recording maximal measures and submaximal measures. Functional performance was also assessed during a 6-minute walk test. The authors found that heart rate and VO2 peak were useful measures when evaluating exercise capacity, that maximal measures were more reliable than ventilatory threshold measures, and that heart rate was more reliable than oxygen measures. The authors conclude that in a clinical setting, the most useful way to assess exercise capacity in children with spina bifida would be through functional outcome measurements and monitoring heart rate. This could be considered a vital study in figuring out how to evaluate and implement exercise training programs for those with spina bifida. In this second study by de Groot and colleagues, researchers have brought up the question of whether VO2 peak obtained by their studies reflected the VO2 max of children with spina bifida. In people who are healthy, VO2 peak and VO2 max are interchangeable. But children with spina bifida may be limited in whether they reach VO2 max by deconditioning or muscle weakness, rather than true cardiopulmonary factors. Determining whether VO2 max and VO2 peak correlate for these children will allow researchers to use the VO2 max and VO2 peak interchangeably. The researchers found that when children with spina bifida are limited by deconditioning or muscle weakness, rather than cardiopulmonary factors, VO2 peak can be used when VO2 max cannot be reached.